Okay. We have in a row two young people, so if you are worried about whether they're going to be new physicians taking care of you for as long as we can all survive, here is another one. Dr. Ramirez is here from the LSU and the Ochsner Clinic, and he is going to talk about, and he's got at least for me, a new sign in here that he's going to have to tell us about. Lung nets, so we haven't heard much about lung nets yet. He's going to talk about those, and DIPNEC, so I'm waiting to hear what DIPNEC is, Diagnosis and Therapy. Dr. Ramirez.
Well, thanks for having me. This is quite the crowd. I want to say a special thanks to Marianne and Bob and Jean. What a great meeting you've put on. So I am a medical oncologist. I'm trained specifically in thoracic oncology, and I've been at the NOLA-NETS group for 4+ years. And I have the opportunity, the unique opportunity to divide my practice into two different pieces. Half of what I see is general thoracic oncology, so your garden variety non-small cell lung cancer, small cell lung cancers, mesothelioma. The other half of what I see is neuroendocrine tumors, including neuroendocrine tumors of the lung. So that's what I'm going to talk about today. I think it's a underrepresented population when it comes to neuroendocrine tumors, but we'll try to fix that. So we'll talk about diagnosis and treatment. Okay, so what I'll outline today is I'll initially start out with some of the epidemiology of lung cancer, why lung neuroendocrine tumors are different, why lung neuroendocrine tumors are different than other neuroendocrine tumors that you've heard about today, how to diagnose this, some of the treatment options, and then we'll take questions afterwards. So lung cancer is very, very common in this country and worldwide, and in this country, well over 200,000 patients get diagnosed with lung cancer each year. It is the deadliest cancer in the worldwide and also in the United States. It kills approximately 160,000 patients each year, and it kills more than breast, colon, prostate, and pancreas combined. So it's a devastating disease. Surgery is sometimes curative, but most patients present at an advanced stage when they're not, when cure is not the option. And when we break lung cancer down, the majority of it is what we call non-small cell lung cancer. The other pieces that you can see here, these are your neuroendocrine tumors. So they include large cell neuroendocrine, small cell neuroendocrine, and also the carcinoids. Now, the pulmonary carcinoids is what I'm going to focus on today, which only represent about 2% of this piece of the pie. So they do represent a broad spectrum of diseases. And again, they range from typical carcinoids, atypical carcinoids, large and small cell neuroendocrine carcinomas. And they're really defined by what they look like underneath the microscope. So this is sort of a busy slide, and what I really want to focus on is just the classification of these tumors. When we look at typical carcinoids, we look at something called the mitotic rate, and the mitoses per 10 high-powered fields with typical carcinoids is less than 2. For atypicals is 2 to 10. there is no necrosis in typical carcinoids. With atypicals, we can see this. And that is different than the large cell and the small cell, where you see a extensive necrosis and also a higher mitotic rate. So this is a Kaplan-Meier curve. You've seen quite a few of these. Just to rehash, anything that is up on top is good. When we look at things coming down here, this is decreased survival. So time, and then the probability of being alive. So the typical carcinoids you can see on the top tend to do better than the atypical carcinoids, which tend to do is compared to the small cell and the large cell neuroendocrine carcinomas, which do extremely poorly. So, and they're classified differently than other GI neuroendocrine tumors. So I'm sure this slide was presented at some point over the last day and a half, but the grading system, G1, G2, and G3, is based on the mitotic index and also the Ki-67. So with less than 3 to 20, and over 20 for G1 to G3 respectively. And that is all based on survival. So when we go back and look at these things, the G1s survive longer than the G2s, survive longer than the G3s. Now, as I said, this is different, and Ki-67 is not included in the classification system for lung neuroendocrine tumors. However, there is some data saying that it may be useful. This is a paper that looked at lung neuroendocrine tumors and divided them between KIs of less than 5% and over 5%, and you can see a very big difference between the two arms. I will say Ki-67 can change over time. This was a study of over 300 patients, and 43 of these patients had multiple biopsies upon progression. Oh. Okay. Okay. Well, 37% of them actually had changes to grade based on Ki-67, and 75% of these patients had upstaging. And we've all seen some of these patients who have been cruising along with low KIs for a long time, and then all of a sudden their disease starts behaving badly, and we go back and rebiopsy, and lo and behold, that KI of 2% is now 15%. So we're not quite sure, why this happens. What I would say, okay, so we'll talk about some of the symptoms of lung neuroendocrine tumors, and they vary. So they can range from cough. You can have hemoptysis, which is coughing up blood, dyspnea, or shortness of breath, wheezing. We see people who've lost weight, a hoarse voice, depending on the location of the tumor. Sometimes people can have pain associated with this, not just in the chest, but also bone pain. And one of the telltale signs that we see is people who have recurrent lung infections. One of the scariest things is when patients get a chest X-ray done incidentally for whatever reason, and I've seen this many times for pre-employment physical, and their chest X-ray has a mass on it, and they were asymptomatic. So how do we work this up? So chest X-ray, oops, I had some pictures on here, but we get a chest CT, including the abdomen and pelvis, sometimes a PET CT, an MRI of the brain, an octreotide scan, and you've heard a lot about the newest imaging modality on the block, the gallium-68 PET CT. So the biggest issue with diagnosis, and this is sometimes a very difficult tumor to diagnose, is you need tissue. And sometimes what we have are small biopsies that don't always give us the best picture of things. And we really do need a multidisciplinary approach. And we have a thoracic tumor board that we meet every week, and we discuss our cases, and it is the whole gamut of people who take care of these thoracic malignancies. So for medical oncology, thoracic surgery, pathology, pulmonary, and so forth. Sometimes, depending on the location of the tumor, you do need neurosurgery or even orthopedics to come in and comment. So how do we go about all of this? So bronchoscopy. Now this is using a tube with a camera going down and into the windpipe, into the lungs, and this can allow for washings and biopsy. Sometimes we use a procedure called a mediastinoscopy, which I'll show a picture of, an endobronchial ultrasound, which is very useful. We can sometimes do a thoracentesis, which is taking a needle and putting this into the pleural space to drain fluid, and sometimes we can get a diagnosis like that. Or a pericardiocentesis, which is doing that same procedure except putting it in the pericardial space surrounding the heart. Sometimes we do a CT-guided biopsy, and if all of those fail, we can go to an open biopsy. So my pictures are not showing up here. Okay, so I had some pictures of what these structures look like, including mediastinoscopy. So mediastinoscopy, when they do it, basically they make an incision right above the breastbone, and they dissect down into the area in between the lungs called the mediastinum, and there's lymph nodes in that area that they can get to and sample those. So, and why does all of that matter? Well, it matters because, as you may have heard about, everyone is concerned about what's the stage of my tumor. Now, there's a lot, and there's reasons for that. And when we look at staging, and this can be very, very confusing. So we base staging off of basically the size of the tumor, if there is spread to the lymph nodes, and if there is spread beyond. And I'm not going to hold you to all of this. I hold my fellows to this because this is very, very confusing. But tumor, the node, if it's spread to the nodes, and if it is spread distantly. And then we have this complex staging system where we label anything from stage 0 to stage 4. But in general, stage 1s are confined to one location in the lung. Stage 2 is confined to one location and a first order of lymph nodes. So when we have, and the pictures didn't come up unfortunately, but basically we have 3 sets of lymph nodes. The first set is, if your tumor is on the right, this is closest to the tumor. The second order of lymph nodes is generally in the middle of the chest, and then the third order of lymph nodes is either on the opposite side of the chest or in the neck. So if that's the case, that would be called a stage 3. And then stage 4s are anything distant, so any evidence of metastatic disease. And why does it matter? Because prognosis and treatment options. So let's, okay, well, I had a nice slide up here about some of the, let me see what, okay, so I seem to be missing lots and lots of pictures here, unfortunately. Basically, stage 1s survive longer than stage 2s, and so on and so forth. Typical carcinoids survive longer than atypical carcinoids. So hopefully these pictures show up here. So let's talk about DIPNEC, which stands for diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. It is a very, very rare disease. When you look through the literature, there's a smattering of papers in mainly single-center institutions or papers. The largest series had 30 patients in it. So again, very, very rare. And basically this is a diffuse proliferation of neuroendocrine cells which are limited to the basement membrane. This tends to affect women in the 5th and 6th decade, and we tend to think that this is pre-neoplastic, so this can develop into a carcinoid tumor. And they can be present with carcinoid tumors or what we call tumorlets. So it's very non-specific symptoms, and when I see these patients, how they will generally present is with a cough or shortness of breath, and they have been misdiagnosed for years and years and years as asthma or COPD, despite the fact that they've never smoked. Sometimes they can show up on a chest x-ray or CT as having pulmonary nodules, and you really need to diagnose it with a surgical resection. It's uncommon that we're going to be able to get a good enough specimen based off of a needle biopsy. And there was actually also just a paper that came out suggesting a clinical diagnosis of this. So they had suggested a DIPNEC syndrome, which had to do with the symptoms of cough and wheeze in the right clinical context with the right findings on the CT without a histologic diagnosis. I don't know if we're ready for that just yet, but I think people are learning more and more about this. So this is a group of patients of 9 symptomatic and 10 asymptomatic patients. And so what you can see here is primarily affected females who were never smokers, and the symptoms of cough, shortness of breath, chest pain, hemoptysis, with a history of asthma. And what I want to stress with this is one thing, is the mean duration of illness prior to the diagnosis was almost 9 years. So does that sound familiar to some of the other carcinoid tumors? So how do we treat it? Sometimes if it's asymptomatic, we don't do anything. We observe it. Sometimes these patients most of the time have been on steroids and inhalers with some varying degree of success. Somatostatin analogs may play a role in this, and I'll talk about that. And in severe cases, there have been some papers supporting the use of lung transplant. So what's our experience with this? We published this last year, and this is in a series of 5 patients, 4 of them who went on a somatostatin analog, and 4 of them had either complete symptom resolution or improvement of their symptoms. So again, very small numbers, but it's something to consider in the treatment of your patients. So let's shift gears a little bit and talk about typical and atypical carcinoids. Typicals are much more common. There is no sex predilection, and it can occur at any age, and in fact, it is the most common lung tumor in children. So how do we work this up? Again, there is a role for conventional imaging, like I just talked about, but also some of the nuclear medicine. So PET-CT, FDG PET-CT, this is the one we usually use in other types of cancers. does play a role. However, the SUV max, or how bright these things light up, is much less than someone with non-small cell, for instance. But about 80% of the time, this will be positive. Octreotide scanning is also indicated in these patients. And then again, the newest one is the gallium-68. What about the biochemical assessment? So this can vary, and it depends. What we generally will do is check a chromogranin and the pancreastatin and your kidney function. If there is evidence of syndrome, we'll check 5-HIAA. If there is Cushing's syndrome present, we'll check cortisol levels and ACTH. And then there's some suggestion about something called pro-GRP or serum serotonin, and then growth hormone if there's acromegaly. And then there's a question about whether or not gene expression profiling adds anything with this. And really, all of this is controversial and evolving. So what we're doing today is likely we're going to be doing something much different 10 years from now. So stay tuned. As I mentioned, the frequency is the typical carcinoids are much more common. And these are generally considered lower grade tumors. However, about 15% of the times, even the typical carcinoids can have evidence of lymph node metastasis at presentation, and 3% of the time distant metastasis. Now, with atypicals, those numbers go up quite a bit. So up to 50% of patients will have lymph node metastasis with your atypical carcinoids, and 20% of the time have distant disease at presentation. And the prognosis with distant disease is poor. So what are our treatment options? So I break this into two different categories, basically: surgical or medical. So primary resection, or taking out the site of metastatic disease, or medical. So chemotherapy does play a role, targeted therapy, radionuclide therapy, which you've heard lots and lots about today. We use liver-directed therapy, somatostatin analogs, maybe, and then I always advocate for clinical trials. So first-line treatment is surgery. These are tumors, these are real cancers, and I've spoken with lots and lots of patients with lung carcinoids, and they have been told, oh, it's just a carcinoid, we don't need to do anything about it. That is incorrect. These are real cancers and need to be treated appropriately. So surgery is always the first option. There are different types of procedures, and unfortunately this didn't come up. But there is something called a wedge resection, where you're taking basically you're basically taking a wedge of the lung, taking that sample of just the tumor without any surrounding tissues. What we generally will like to do is an anatomic resection with a lobectomy. There's 3 lobes on the right and 2 on the left, so we take the entire lobe. And most people tend to do well with that. That's the standard of care for these types of tumors. But sometimes we can get away with something called a segmentectomy. So there is segments in between each one of those lobes. Pneumonectomies we try to avoid if we can, where we take the entire lung. And then there's something called a sleeve pneumonectomy. And what I would say with any of these procedures, they should be done at high volume centers by people who know how to do this, so thoracic surgeons. So beyond surgery, so there's very few prospective studies, and someone alluded to us medical oncologists like these randomized studies. Well, we do, and there's a reason for it, but unfortunately, with these rare tumors, we don't always get that. So most of the data comes from case series and case reports and lower levels of evidence. As I mentioned, if you have node-positive disease, this worsens the prognosis. So after surgery, generally in other types of cancers, if you have evidence of disease in your lymph nodes, we will generally do what we call adjuvant treatment, so chemotherapy generally for a period of time. And unfortunately, we don't have the data for this. So there's no standard treatment. So do we do somatostatin analogs or chemotherapy, or do we just watch and wait? Well, we really need to look at this intelligently and design some trials for this. There was a trial that looked at patients who had gotten adjuvant therapy. And this is back in between 1980 and 2009. I did 127 patients with atypical carcinoid tumors of the lung. And it turns out there was no difference in survival in patients who had treatment and who did not receive treatment. But what they did see is those patients who had less than an entire lobe taken out, they tended to do worse. And treatment was, again, primarily based on your staging. All right, my picture showed up here. So you learned about what the NCCN guidelines were yesterday. And basically, this is the lung neuroendocrine tumor guidelines. And what we see with the stage 2 and 3 adjuvant, they recommend combination chemotherapy with cisplatin and etoposide, which are traditional chemotherapeutic agents, with radiation, or plus or minus radiation. But the other thing you see down at the bottom is it says there is no substantial evidence for the preferred regimen. So, and that is coming from the NCCN guidelines. So what about progression? So somatostatin analogs play a role, chemotherapy sometimes, targeted therapy, and radionuclide therapy. For somatostatin analogs, again, not a whole lot of data for in lung specific. We tend to think there are some smaller trials or trials that have included GI nets and lungs that do show an anti-proliferative effect. And what I would say is clinical trials are needed. There is one clinical trial, the SPINET trial right now, that looks at patients with metastatic neuroendocrine tumors of the lung that have progressed and randomizes them to lanreotide or placebo. So this is a worldwide trial. It is open at our institutions and several other institutions in the United States. So it's something to be on the lookout for. Hopefully we'll have an answer. What's the role for chemotherapy? So I just mentioned the NCCN tells us that chemotherapy may be indicated. We generally will use a platinum along with etoposide. This looks at several different studies, and we can see the response rates are somewhat variable depending on the study, up to 56% response rate, which is a very, very good response. But some of the lower grade tumors tend not to respond well. But I think in the right patient, sometimes cisplatin and etoposide is a good option. You may have heard about combination chemotherapy with capecitabine and temozolomide. This was a study that did include 29 patients, 8 of them were lungs, and it turns out there was about a 14% partial response and stable disease in about 59% of patients. What's our experience with it? We published this earlier this year, and this was all comers. However, we did have 4 lungs, and 50% of them had some evidence of disease stability. So other chemotherapies have been described in case reports, including a regimen called FOLFOX with Avastin. Again, it's something to consider when your patient is sitting in front of you and you don't have much else. Unfortunately, these pictures didn't come through. You heard about the Radiant 4 trial with everolimus, which included patients with carcinoid tumors of the GI tract, but also lung. So this is the best data that we have. So this is now, it did show a 52% reduction in progression in patients who were on the everolimus group. So this is also an option. Peptide receptor radionuclide therapy, we've heard all about. Again, no specific trials designed just for lung. However, there is some data suggesting that if you have uptake on your octreotide or your gallium-68, you may benefit from this type of therapy. And then we have something else called MIBG, which you do need to have uptake on an I-123 MIBG scan. So we presented this last year at the World Lung Meeting, where we had six lung carcinoid patients. Most of them were typical, and about half of them had clinical benefit with a median overall survival of about 16 months. So genomic profiling, again, stay tuned. I don't think it's ready for prime time just yet, but I think, again, as we're learning more and more about the molecular targets in other cancers, I think we're going to learn more and more about the molecular targets in neuroendocrine, specifically neuroendocrine tumors of the lung. So what I'll conclude with is I hope I've convinced you this is a wide spectrum of disease, from very, very indolent to very, very aggressive. They compromise, they can comprise nearly 1/4 of all lung cancers, so it is relatively common when we look at how many people get lung cancer each year, although carcinoids do represent only about 2%. There are no benign carcinoids. They all have the potential to spread. There are quite a few treatment options, but clinical trials are desperately needed. So I'll stop there, and thank you for your attention.